Hello, this is Dr. Benjamin Strong, the Chief Medical Officer of Virtual Radiologic, or VRAD. Thank you for joining me for this presentation on artificial intelligence and epidural fluid collections. We have been running artificial intelligence algorithms for a number of pathologies for well over a year at this point. And epidural fluid collections was one of the first such algorithms that we developed. Before I discuss missed findings, I always like to put things in perspective and show you our quality assurance data based on 2 decades of extensively overread radiology reporting. So our major miss rate, that is a major miss per 1,000 studies read, averages across time and across the practice at about 1.3 major misses per 1,000. To compare that to other major miss rates throughout the radiology literature, the Wilson-Wong study, probably the largest and most relevant as it was for overnight teleradiology emergency studies, much like our volume is, that came in at over 5 major misses per 1,000. The SOFA study from Dallas was only about 700 patients, and they were trauma patients, so there was a higher miss rate there that approached 30 misses per 1,000. And then lastly, the other oft-cited QA literature is the Wu meta-analysis. And of course, any statistician will tell you that a meta-analysis is just another way of saying garbage in, garbage out, but that came in just under 25 misses per 1,000. So I think compared to the most relevant other QA study, we are about 3 times as accurate as a typical practice, and I do believe that is legitimate. We are overread to such an extent that has, over the years, created a culture of marked quality. We categorize all QAs submitted to us every year and have been doing that for at least 3 years now. We're in our 4th, in fact. So we have 3 years of quality assurance data with numbers for each of the anatomic and pathology categorizations for all of our QAs. So this is 3 years of data, 2019 through 2021 inclusive. And I'll just give you the punchline here. The most frequently missed thing is a pulmonary embolism. Next most is spine fractures, with fracture in general being the largest pathologic category of misses. And third place comes intracranial hemorrhage. So we use this information to build our algorithms for the specific pathologies that we know are most frequently missed, which I think is a brilliant approach. So why do we have an algorithm for epidural fluid collections, that being hematomas and abscesses? Well, that comes from our medical malpractice assessment. I have gone through 45 cases that closed with indemnity, meaning a payout of some kind, either a jury award or a settlement. 45 cases over an almost 4-year period. Now, these cases, of course, actually spanned a period of almost 9 years, but these closed over a 4-year period. Of those 45, 35, I determined, were actually avoidable, related to primarily or solely a diagnostic error, a missed finding that resulted in a bad patient outcome. So out of those 35 cases, here were the pathologies and how they broke out. And as you can see, epidural abscess was 3, aortic dissection 4, and ischemic bowel 6. Those were the most represented pathologies across all of our med mal experience. And the totals for medical malpractice indemnities or jury awards are as you see here. So epidural abscess was actually the most expensive medical malpractice case you can have. We've taken this information, both our medical malpractice and our QA data, and we have determined that these are the most useful algorithms to build from an artificial intelligence standpoint. As you can see, I've got numbers for the study volumes we read of relevant studies, the number of QAs, the detected by AI cases, the number of cases that became medical malpractice cases, and the pathology incidents revealed by natural language processing reviews of our archives over a solid year. So the dates don't necessarily add up, nor do the volumes. So what I've done is put these all, we did a little math here, I put them all per 1 million studies. So now you can see the expected QA rate per 1 million studies, AI detection per 1 million studies, medical malpractice cases per 1 million studies, and pathology incidents. And that is of relevant cases, meaning for, say, the epidurals, those are run on neck CTs and cervical, thoracic, and lumbar spine CTs. So we're only counting relevant cases there where you might stand a chance of actually seeing that pathology. So here is our computation of the incidence per million studies for each of these pathologies. And by the way, on the far right, occlusion is for superior mesenteric artery occlusion, and laceration is for splenic laceration. Dissection, of course, is for aortic dissection. All right, so now we have the incidence of these pathologies per million studies. We can do a lot more computation. We can come up with the number of those pathologies that are missed per million studies. Then the standard miss rate. If it's present, what is the likelihood it will be missed? And as you can see here, epidural carries the day at 35%. 35% of epidural fluid collections seen on CT scan are missed. And that is a pretty incredible number, and that's the one that really inspired us above all to make an epidural fluid collection algorithm. You can see the conversion rate for medical malpractice, the average indemnity, the dollars per million studies that are saved by running an AI algorithm that catches all of these pathologies, and then the dollars per year, which reflects the number of the relevant studies that we do. So the dollars per million studies, again, the epidural carries the day at $2,184,000 saved per million studies. And that's, again, related to the high average indemnity and the high miss rate that we have for epidurals. So with that as a pretext to explain to you exactly why we built the algorithm that we did, I'd now like to share with you the results of a month of epidural algorithm findings. Basically, I have 20 cases of epidural fluid collections. They are a mix of hematomas and abscesses, and we don't actually know necessarily which in each case. These are basically cases that the artificial intelligence algorithm identified as fluid collections in the epidural space. We use natural language processing to assess that radiologist's report at the time, and if it does not describe an epidural fluid collection, then it goes to our quality assurance committee. So all of the cases that I'm about to share with you, and there are 20 of them, are essentially a month's worth of algorithm product that are studies we identified with our AI algorithm, but that were missed by the radiologist. And they received ultimately final sign-off and approval by our quality assurance committee and were agreed to by the respective sending facilities. So with that, let's look at 20 cases of epidural fluid collections. Our first two actually have just the axial images. I use a third-party exporting program to generate these cine versions of cases. And as a result, some of the sagittals are not of the greatest quality, but I want to point out that those sagittals are a result of my processing and are not similar to the sagittal recons that were available to our radiologists. Here's a second case. Note, in most of these cases, part of the problem, part of the reason that they were missed is because they are so extensive. Right? When you have a finding that is so extensive that it makes a normal structure or an abnormal structure look normal throughout its extent. That can be a real fooler. You see it with bone marrow changes on MR, say infiltrating marrow changes like lymphoma and other metastatic disease. And you see it here both in CT and MR for epidural hematomas or abscesses that are truly extensive. So you can see those first two cases were pretty much top to bottom cervical spine involvement. Now we've got a number with both axial and sagittal images. And again, a very similar phenomenon here, where there is such extensive involvement, it makes all of the spinal canal look the same density and becomes very difficult to identify. I'm going to let each of these run 3 times through so that you have a chance to look at both the axials and the sagittals. Here's case number 4. That one appears to be nearly circumferential. It's actually a little more prominent posteriorly, inferiorly, and anteriorly, superiorly. Here's case 5. Pretty marked distortion of the upper cervical cord in this one. But again, very extensive involvement with little normal canal visible at any level. Case 6. Again, that extensive involvement making it difficult to detect at any level. And case 7. This one is most prominent superiorly. And the distortion of the canal in those higher cervical levels would probably call your eye to this one. Case 8. Again, this is prominent posteriorly inferiorly and anteriorly superiorly. On to case 9. This one is most prominent posteriorly inferiorly. There is also a small component anteriorly and superiorly. Let's go on to case 10. This is a tricky one. There's a thin epidural collection anteriorly that only becomes slightly lobulated and irregular at the highest levels, right there on the axial images. And that's what really tells you that what you've been looking at throughout the rest of the cervical spine is in fact an epidural fluid collection. All right, on to case 11. And this one's really just present superiorly, just under the skull base really is where it's most prominent. On to case 12. This one is an anterior collection, and it's the lobulation that really calls your eye to it, especially on the sagittals. You can see that lobulated collection there, creating almost an undulant border right there. Case 13. This one is mostly posterior and inferior. Of course, there's always a lot of artifact from the shoulders near the thoracic inlet and lower cervical spine. This one still is visible, though. And case 14. I think you've got it throughout here, but probably most prominent anteriorly. All right, so about 70% of our cases were cervical spine. We'll move to the thoracic spine. This is case 15. This is something that characterizes all the thoracic spine epidurals that our radiologist did not identify. It's that extensive involvement throughout the entirety of the spine. Hyperdense collection there, easily visible posteriorly on the sagittal as well. All right, moving to case 16, very similar appearance. Really all of our thoracic fluid collections or epidural hematomas, I think in all of these cases, are very similar in appearance with that extensive involvement, tricking the eye into thinking that that is just normal CSF density throughout the spine. And case 17. Got a magnified dedicated thoracic spine view on the right. These are the same patient at the same time, though. You can see there's a little lobulated contour to the canal that tips you to the fact that something is abnormal, in addition to the fact, obviously, that the canal is far too hyperdense throughout its extent. And now we'll go to a few lumbar cases. This first one is actually one of the few that we know definitively to be an abscess rather than a hematoma. You can see it surrounds the inferior aspect, really the sacral canal. The ill-defined density surrounds the thecal sac, and there are even presacral soft tissue changes present, as well as a subcutaneous fluid collection. All of those things should tip you to the fact that this is, in fact, an inflammatory or infectious process. That's a very nice case, though. One that is tough. On the sagittals, you can see a little distortion of the thecal sac and that added density right there. Another lumbar case, this one associated with a fracture with retropulsed fragments. Of course, when you see a fracture such as this, you should investigate that anterior epidural space and basically look until you find it. This one is relatively subtle. It just spans, say, the vertebral level inferior to the fracture itself, but nonetheless, it is clearly present. And lastly, another epidural associated with a fracture, this one spanning perhaps 2 vertebral levels, but anterior as well, a typical location for one associated with such a fracture. Nice example. All right, folks, that concludes our presentation on artificial intelligence and epidural fluid collections. That was a month worth of artificial intelligence algorithm collected misses on epidural fluid collections, mostly hematomas and certainly a few abscesses as well. Hope you found that helpful. As I mentioned, this is one of the most frequently missed findings and can be a very expensive one from a medical malpractice standpoint as well. Thanks again for your attention, and we'll see you on another lecture soon.